Hello, Kim, can you hear me?
I can. You're a little quiet.
I have
something
my
else?
mask on. Probably that's what it is.
There we go. Okay.
Okay.
Kim?
Good afternoon, Dr. Freer. Did you want to go ahead and get started?
Yep, thank you.
Okay. Good afternoon, everyone. Thank you so much for joining us today, the Los Angeles County Department of Public Health, for a media briefing. Today we have the Director of Public Health, Dr. Barbara Freer. Dr. Freer will present and then she will take your questions. As a reminder, use the hand icon or you may chat me, the host, to ask a question. Dr. Freer, when you're ready.
Thank you. Good afternoon. Thanks for joining today's briefing. As always, I'll open with a status update, review current metrics for our early alert signals, and discuss some key protective measures needed as we prepare for the summer ahead. Following my remarks, I'm always glad to respond to any questions. First slide. This past week, we saw a renewed increase in reported cases after slight decreases last week. Continued upward movement in test positivity and hospitalizations, and a stable number of reported deaths. Over the past week, we reported many more cases compared to last week and are reporting 4,846 new cases today. As we noted last week, this number is an undercount since it doesn't include positive test results from the over-the-counter tests. The average number of daily new cases reported this past week increased by 13% from 1 week ago, 93% from 1 month ago. The 7-day average daily case rate also increased and is now at 48 cases per 100,000 residents. Test positivity also increased. It's at 4.7%. That's about double the test positivity rate from about 1 month ago. The steady increase in hospitalizations continued, and the 7-day average daily hospitalizations are about 544. Average deaths, fortunately, remain stable at about 7 deaths reported per day. Each death, however, is an acute loss, which ripples out through families in the community. We know and we understand that those affected are forever changed by this terrible pandemic, and our thoughts and prayers remain with those families. Next slide. These are the latest trend lines for 3 key metrics: the 7-day average daily cases, hospital admissions, and deaths, and they reflect the continued increase we just talked about. The 7-day average daily reported cases, that's the green line, is now back up to nearly 4,900 cases after a slight decrease earlier this month. The earlier decrease was likely related to lower testing over the Memorial Day holiday, while the subsequent increase may be related to increased spread associated with travel and gatherings during the long holiday weekend and as we head into summer. The rate of hospital admissions, as you can see, has increased incrementally. The 7-day average daily hospital admissions, that's by the orange line, that's about 77, which is more than 135% higher than admissions were 1 month ago. The 7-day average number of reported deaths, the blue line, remains stable at about, as I noted, 7 deaths a day. Next slide. This week, we remain at CDC's medium community level. The weekly case rate is 310 new cases per 100,000 residents this week. Both of the CDC community level hospital metrics, as you can see, increase. The first hospital metric, the 7-day rate of new admissions per 100,000 people, increased to 6 new admissions per 100,000 residents. That's about twice as high as it was 1 month ago. The second hospital metric, the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients, increased to 3%. Although these hospital metrics are still below the threshold for high in CDC's community level framework, the continued increases have us closer to meeting the high level threshold of 10 new admissions per 100,000 people. You can see we're at about 6.4. Next slide. This week, we repeated our analysis on when hospital admissions might surpass 10 new admissions per 100,000 per week. If they continue to increase at the same rate that we saw the last 2 weeks between May 24th and June 6th, hospital admissions could hit the level of 10 new admissions in early July. This is a little later than we had projected last week, and the change is because the rate of increase in hospital admissions slowed slightly these past 2 weeks. As a reminder, the projection on this slide does assume that we maintain the same average rate of increase in the rate of hospital admissions that we saw over the recent past period. And as I'm just showing you, that changes. So the actual rate of change in hospital admissions could be very different as we move forward. Nonetheless, an important strategy for lowering hospital admission is to reduce community transmission. Given that there's a customary lag in hospitalization increases, should we reduce the number of new cases over these next 2 weeks, we could see a subsequent decline in new hospital admissions a couple of weeks later. Next slide. This week, the majority of our 8 early alert metrics continue to convey cause for medium or high concern. The only early alert signal of low concern is the number of sewer systems with a 2-fold or greater increase in wastewater SARS-CoV-2 concentration. While wastewater concentration of SARS-CoV-2 remains high, there were not any significant reported increases in the high concentration levels over the last week. Unfortunately, the number of new outbreaks in skilled nursing facilities, as you could see here in the past 7 days, is again of high concern, with 40 new outbreaks reported this past week across the 341 facilities in LA County. And both the case rate in the lowest income communities and the percent of specimens identified as new variants of concern continue to signal this high concern level. I will provide some additional details regarding some of these early alert signals in the next few slides. Next slide. Omicron continued to account for all positive cases for sequence specimens collected through the week that ended May 21st. Almost 98% of the specimens continued to be BA.2 and its sublineages. The proportion of BA.2 Omicron variant itself, excluding those sublineages, and it's shown in light blue here, appears to be plateauing and continues to account for about half of the specimens sequenced in the county. The BA.2.3 Omicron sublineage, that's that little yellow sliver there, has continued to decrease. This time it accounted for only about 3% of the specimens that were sequenced in this most recent week. It will be interesting for us to see if it disappears completely over the next few weeks. In contrast, BA.2.12.1 sublineage, that's shown in orange, accounted for 42% of positive sequence specimens in the week that ended May 21st. This is a small increase from the previous week. Nationally, CDC predicts that BA.2.12.1 will account for 62% of the specimens collected the week that ends June 4th. The red section at the top of the bar indicates the percent of specimens that tested positive for BA.4 and BA.5 subvariants. As you can see, they continue to remain rare in LA County, but a few cases are being detected every week. To date, we've detected a total of 49 positive sequence specimens of these two subvariants, 27 of BA.4 and 22 of BA.5. The CDC now estimates that across the country, these two variants combined may have increased from about 1% to 13% of specimens collected in the past month. This suggests that they may have the ability to outcompete other circulating variants. There's also concern that they may be able to cause reinfections in people who have already been infected by other Omicron subvariants. Because of this rapidly changing variant landscape, it remains important to use measures that are protective against all the variants, including masking, moving activities outdoors, maximizing your ventilation when you're indoors, and testing and staying home if you're sick. We continue to follow the increases in the Omicron sublineages BA.2.12.1, BA.4, and BA.5 closely, and we're assessing their impact on our case rates, hospitalizations, and deaths. Next slide. Throughout the nearly 2.5 years of this pandemic, we've remained deeply concerned about the effects of this virus on those living in communities with fewer resources and who've experienced higher overall case, hospitalization, and death rates. This is the reason why one of our early alert indicators is the 7-day case rate for the lowest income areas. This past week, the 7-day case rate for the lowest income areas, shown by that red line, is of high concern for a second week in a row, having increased from 220 new cases to 232 new cases per 100,000 residents this past week. We've seen in past surges that they can sometimes start first in the higher income areas before moving into lower income areas where there are fewer resources and the potential for more exposures at work sites and in the community. The 7-day case rate, as you could see, fell sharply for residents in our lowest resource communities, but they also fell sharply for all income levels around Memorial Day. Again, similar to what we saw earlier on the trend lines, this is likely due to a decrease in testing. However, between May 31st and June 6th, as you could see, the case rate sharply increased by 23% in the lowest income areas, and that's compared to about a 10% increase in the highest income areas. This may indicate the beginning of a shift where the spread is now happening. We'll continue to monitor this information closely and align resources with appropriate mitigation actions. Next slide. Unfortunately, as I noted earlier, the number of outweeks per week in skilled nursing facilities, as shown by the purple line, increased sharply this past week to 40 new outbreaks during the 7 days that ended June 7th, returning the level of concern to high. The sharp increase reflects increase in transmission in the wider community. When we strongly recommend universal COVID precautions, one of the reasons is because we have a collective opportunity to protect the most vulnerable in our community, including our residents in nursing homes. While hardworking staff can and they do take extra measures to prevent transmission at these facilities, if transmission rates are high in the surrounding community, it increases the likelihood that residents and staff will be exposed to infected individuals. When we mask and we take other protective measures during times of rising COVID cases, we're taking steps to protect all of our residents, including the most vulnerable at our nursing homes. We're working closely with skilled nursing facilities to investigate and stop the outbreaks. And as a reminder, an outbreak at a nursing facility is just one case in a resident. Workers and residents in these facilities continue to maintain enhanced protective measures. This includes indoor masking and testing requirements for residents, staff, and visitors, appropriately isolating and quarantining residents, and we continue to have to limit communal dining and group activities that can't happen outdoors. During the same time frame, as you can see, new outbreaks for people experiencing homelessness, as shown by the green line, decreased slightly, keeping the level of concern at medium. Our teams continue to facilitate testing and referrals to quarantine and isolation sites, and we're providing easy access to masks, vaccinations, and boosters for people who experience homelessness. Masking indoors remains required at all shelters and interim housing sites. Next slide. The early alert metrics also signal a continued increase in the reported COVID-19 transmission that's happening at work sites, as you can see here, with 259 worksite cluster reports received for the 7-day period that ended June 7th. This is an increase from 186 worksite cluster reports that we received for the week that ended on May 31st. Twice as many cluster reports as we reported for the 7-day period that happened a month ago. Of these worksite clusters, the majority are from 3 sectors, with 23% in the retail trade sector alone, particularly at food and beverage stores and building material and garden equipment and supply dealers. Other businesses that were frequently represented were manufacturing and also professional, scientific, and technical services sectors. And a lot of that was in offices. There is an excellent COVID-19 safety guidance and signage that businesses can use on our website. We also have a team of COVID-19 liaisons that are ready to help answer questions from businesses. Keeping workers and workplaces safe from COVID spread during high transmission is not easy, and it requires multiple measures as well as an ability to cultivate a culture of safety. We recognize and thank the many businesses throughout the county that are doing exactly that. Next slide. School classroom outbreaks remain at medium concern as they have for over a month now. For the week ending June 7th, there were 11 new classroom outbreaks. 8 were in elementary schools, 1 was in a middle school, and 2 were in high schools. Throughout the past month, there have been 15 large outbreaks associated with end-of-the-year field trips, school performances, and events such as proms, with over 750 cases among students and staff involved in these 15 outbreaks. Next slide. As expected, with high community transmission, the number of cases among students and staff increased nearly 75% over the past month. For the week ending May 29th, there were 7,854 cases in students and staff in schools across the county. 6,362 were among students, 1,492 were among staff. For context, a month before, for the week that ended May 1, there were 4,479 cases, the vast majority, of course, among students, and 832 among staff. Test positivity also doubled this past month at schools, although it remains low. For the week that ended June 3rd, the test positivity was 1.2% compared to 0.5% for the week that ended May 6th. The highest case rate in the county is among teens 12 to 17, with 762 new COVID-19 cases per 100,000 teens. This rate is more than double the rate 1 month ago, when there were 363 cases per 100,000 teens. As of June 4th, the case rate for children 5 to 11 also had increased. It's now at 588 new cases per 100,000 children. This is a 96% increase from 1 month ago when the case rate was 300 per 100,000 children. That was on May 4th. The high case rate, again, reflects this elevated transmission of the Omicron variants among children. And while most children will experience mild illness, unvaccinated children are at increased risk of severe illness and multisystem inflammatory syndrome in children, MIS-C. Over the past 3 months, unvaccinated children ages 12 to 17 in LA County were nearly 4 times more likely to be hospitalized than vaccinated children in the same age group. Additionally, 65% of vaccine-eligible children with confirmed cases of MIS-C were in fact unvaccinated. Having just looked at the data on cases and hospitalizations among school-age children, I do want to take a moment to address the common misperception that COVID causes always and only mild disease in children. We should make no mistake, COVID-19 is a concerning childhood illness. Across the country, over 1,500 children have died from COVID since the start of the pandemic. And about 1 in 3 children that were hospitalized with COVID ended up in the ICU. In LA County, there have been 11 COVID deaths among children since March of 2020, but there's only been 1 flu death among children over that same time period. A new study that is still in preprint was just posted examining the top causes of death in the United States in children between March 2020 and April 2022. They found that COVID-19 ranked number 9 among all causes of death for children between the ages of 1 and 19. COVID-19 ranked number 5 in disease-related COVID causes of death, and it was number 1 in deaths caused by infectious respiratory diseases. Next slide. Starting next week, many children will be out of school and they'll be starting recreational programs, including camps, offering them an opportunity to explore our beautiful county. We want to encourage parents to spend some time reviewing the COVID safety protocols of the recreational programs and camps where their child may be going, and also to prepare their child to be as COVID safe as possible. COVID safety precautions and recommendations are very similar for schools and for camps. As at schools, there is a risk of outbreaks, especially for camps that have a lot of indoor activity. One of the essential steps a camp can take, and a recreational program as well, is to have clear COVID protocols that are shared in advance with parents and campers. Included in these protocols should be a well-defined process for assuring that everyone is healthy on a daily basis. We strongly recommend that camps and recreational programs require masking indoors and in vehicles. This is one of the simplest and most effective steps that can reduce risk. As we've seen at schools, routine testing increases safety by identifying asymptomatic infected individuals who can then be excluded. Overnight camp should consider requiring a negative test before arrival. Day camps and recreational programs should consider requiring weekly testing, especially if these activities include higher risk activities like indoor sports. Camp directors are able to access free tests by contacting us at acdc-education@ph.lacounty.gov. You can give us a call as well at our call center, and we'll connect you if you're managing a camp and need some access to free tests. Reducing widespread mixing and mingling can also help prevent large outbreaks. Cohorting, which is the process of having campers stay within one group while they're at camp, especially when in indoor areas, is one strategy that can be used to limit the potential for viral spread across large numbers of individuals. Given the busy schedules at many recreational programs, it's strongly recommended that as part of infection control protocols, group hand washing be scheduled in several times during the day. This is especially important for younger campers and attendees, and it's very important to do this before meals or snack times. Good infection control standards also should include daily disinfection of frequently touched surfaces. This could be like your door handles, your restrooms, and equipment that's handled by many children. Camps that make maximal use of the outdoors are going to be inherently safer than indoor camps. Even if the core programming is not based on outdoor recreation, holding like group gatherings outside whenever possible will reduce risk, and it will allow campers to more safely remove those masks. Camps can prepare their outdoor spaces now and add some shade and seating to facilitate these outdoor gatherings. For activities that cannot be moved outdoors or for camping during inclemental weather, ventilation should be optimized. If it's safe to do so, open the doors and the windows. Placing a fan in a window that blows outward, this is an exhaust fan, helps draw any virus particles that are in the air out of the room. HVAC systems should be providing between 2.5 and 6 air changes per hour. Higher is needed if there's going to be crowded spaces. And they should have a MERV 13 level filter, as long as the HVAC system can handle it. Indoor areas that are not well ventilated can be made safer by the use of even portable air cleaners that have HEPA filters. While the actions I noted above are central to avoiding spread of COVID at camps and recreational programs, We do urge parents to also make sure that all organized activities for children are appropriately staffed by trained counselors who can ensure optimal safety. This is especially important for activities near or in the water. And as a reminder, camps and recreational programs are required to report any and every case of COVID in a camper, a staff member, or a volunteer to the Department of Public Health. This does allow for swift implementation, as determined by the Public Health Department, of strategies to stop or manage the outbreaks. Next slide. Parents and caregivers can also do a lot to get their children ready for safe and fun camp experiences. Importantly, please be sure that children are up to date on all recommended childhood vaccinations, including for COVID. You can consult your pediatrician or our website, vaccinatelacounty.com, to learn more. Take a moment every morning before camp or before sending a child to a recreational program to ask your child how they're feeling. If they're unwell with any COVID-like symptoms, consider testing them with a COVID home test or consult your pediatrician. Please do not send them to a program that day if they're feeling unwell. This is especially true if they test positive. If they're feeling well and ready for camp, be sure to send them off with sunscreen, hand sanitizer, well-fitting masks, and plenty of water. Next slide. In closing, a couple of quick updates on vaccines. This week, the FDA's advisory committee voted to recommend Novavax's COVID-19 vaccine for use in the United States. As a result, the FDA may soon decide to allow use of Novavax in the US by granting emergency use authorization. Novavax is a 2-dose vaccine, and it's designed for use in those 18 and older. It's made based on a long-standing recombinant vaccine technology that uses inactive copies of the virus's spike protein. This is a similar technology that's used in some of our non-COVID vaccines, including the vaccines that are commonly used to protect against hepatitis B. This vaccine can be stored at refrigeration temperatures, making it simpler to store than the deep freeze that's required for storing Pfizer and Moderna's COVID-19 vaccines. The vaccine was found to be 90% effective at preventing infection and 100% at preventing severe disease in data from the clinical studies. But these data, I want to note, were based on studies that were performed between December of 2020 and September of 2021, meaning that most of the study was conducted before Delta predominance and all of the study was conducted before the emergence of Omicron. So the effectiveness of Novavax against Omicron is currently being assessed. Currently, there is no supply of Novavax in the United States, and federal funding has not yet been allocated to purchase the vaccine. However, the federal government has indicated that it may become available sometime in the late summer. The second update is on vaccines for young children. The FDA Advisory Committee that reviews vaccines is scheduled to review emergency use authorization requests for both the Pfizer BioNTech 3-dose vaccine regimen for children between the ages of 6 months and 5, and the Moderna 2-dose vaccine regimen for children between 6 months and under the age of 6 on June 15. On June 14th, the very same FDA Advisory Committee is also going to review Moderna's application for their 2-dose vaccine for children ages 6 to 17. CDC's committee that reviews vaccine use is scheduled to meet to review the vaccines and any FDA authorizations on June 17th and 18th, and they'll issue the final recommendation. This likely means that if approved, vaccine for our youngest residents may be available as soon as June 21st. Orders have already been placed through DPH for many local providers to be prepared for administering vaccines to young children on June 21st, if they're approved. We'll continue to provide updates on the details of the vaccine rollout for young children as additional information becomes available. You can go ahead and bookmark our webpage, vaccinatelacounty.com. Not only will we have the latest information, but we'll also have maps that will list all of the sites that will be administering these doses should they be approved for our youngest residents. After we begin our summer, as we're beginning our summer with a lot of uncertainty regarding the trajectory of the pandemic, given the proliferation of highly infectious new subvariants of Omicron. I do remain hopeful because we all have more knowledge, more experience, and more tools than ever before that we can use to protect ourselves and those that are most vulnerable. By layering in these common sense safety measures that address the very real risks during times of these high transmission, we can feel comfortable doing many of our customary summer activities. Thank you, and I'll now open for your questions.
Thank you, Dr. Freer. As a reminder, if you have a question, you can use the hand icon or you may chat me, the host. I'm also happy to read your question. Our first question comes from Marla Tejas from Fox 11. Marla, you're unmuted. Go ahead.
Thank you. Good afternoon, Dr. Ferrer. Can you hear me okay? I'm using a different setup.
I hear you great.
Okay, great. So with that said, on my different setup, I admittedly had trouble logging on, so I missed 3 minutes, so I missed the daily numbers. I'm assuming that you didn't announce any new major mask mandate in particular. I did log on right when you were saying about hospitalizations entering a high category. Your estimates would be early July. We are, almost mid-June. So does that mean then if we do not curb community transmission and do in fact continue this trendward upward in terms of hospitalizations, would that in fact then trigger you to reinstate the indoor mask mandate in LA County? And then my second question is, you brought up home testing, and your recommendation for use a home test kit for anyone really, for kids in particular. Given that a lot of people are home testing now, and those test results aren't incorporated into your daily count, is there a plan to implement a mechanism to incorporate those home test results into your daily count? And can you estimate how many positive cases there really are on any given day, given that a lot of people are home testing and testing positive? Thank you so much.
Yeah, thanks for both questions. Let me just quickly deal with the issue around masking requirements. Should we enter into that high community level as designated by CDC? That's the framework at the moment that we're all using to determine what actions are most appropriate. I mean, we stay aligned with the CDC recommendations here. And if we were to go into a high community level, they do note that at that point, it makes a lot of sense to have what we call universal indoor masking requirements. So yes, we continue to have masking requirements in lots of places. So many people are familiar with this. We continue to strongly recommend indoor masking in all the other places, but there will not be a move to go ahead and trigger a more widespread universal indoor masking safety measure unless we move into that high community level. I'm going to put one big caveat here. Should we have the unfortunate reality of noting that we have a new variant that escapes our vaccine protections a lot more than the variants are escaping vaccine protections right now, then it's highly likely that we here in LA County, as well as in many other places across the country and the world, would be reintroducing masking safety measures, because that would be the best tool we'd have if our vaccines aren't able to work as well as they're working now. But at this point, we have an opportunity, again, slow transmission, won't have as many hospitalizations. We have time to go ahead and do that, but it would take everybody working a little bit harder at slowing down that transmission, being more careful, wearing masks when you're around other people indoors, doing testing when you're gathering indoors so that you can avoid that unintended spread, so that the gathering, 3 or 4 days later, 5 people are now testing positive. We've all been there. We all know those stories. We've lived those stories. we'd have to do a better job at trying to avoid that. I think your second question is really important on what do we know about the actual level of community transmission that's going on across LA County. As always, the number of positive tests is, been fraught with some inaccuracies. At the beginning, we didn't have enough capacity to test everybody. At some points, we've had delayed testing results, especially when we've been in surges. And we've also had some times where it's been harder for people to get testing. And now we have the advantage, and I want to be clear, it's a huge advantage, the advantage of us being able to have these over-the-counter tests that allow us to test both more frequently and in the privacy of our homes or our workplaces. And those test results are not reported to the public health department. We have at this point in time no intention of requiring people to report those results to us. We have a call center that is set up where people can call if they get a positive test result. We encourage people to call because we can help them. We can help them figure out how to notify their close contacts. If people need support, with isolation and quarantine, we're there to help. And now, especially important, if you test positive and you're at higher risk of severe illness, we can help you get those essential therapeutics very quickly without ever having to leave the house. But there's a lot of variability in how folks administer those home test kits. And so it makes it a little bit hard to figure out how we would be requiring the reporting of that and what we would do differently with that information. One reason that we are pleased to be able to do the wastewater, looking at wastewater concentrations of SARS-CoV-2 is because that is another strategy for us understanding what's going on with community transmission. We could look at the concentration levels. As we noted today, they haven't been increasing dramatically at all over the last couple of weeks, but they remain very high, which really just confirms that we have a lot of transmission. I mean, I will say that modelers estimate that at this point, the testing that we're doing underrepresents by probably threefold the accurate number of people who may be positive on a given day. So, that means, likely we, on any given day right now, we're averaging about 15,000 people that are newly positive. So that's a sobering number, but it's also our reality. Lots and lots of transmission. And we all know that because our social networks are filled with people who are testing positive. So thanks for that. And take the next question.
Our next question comes from Ron Lin from the LA Times. Ron, you're unmuted. Go ahead.
Hi, Dr. Furr, thanks so much for talking with us. We really appreciate it. Our questions today are on future mask mandate, a crystal ball question, and monkeypox. So first on mask mandates, your counterparts in the Bay Area have made differing decisions in relation to mask mandates, even as they report higher rates of new weekly coronavirus positive hospitalizations. Alameda County imposed one last week, but San Francisco is not going there, saying they have ample hospital capacity and think they should save that authority for a worst case scenario. I know LA County is more vulnerable to the worst effects of pandemics compared to the Bay Area, but can you elaborate more on why you think it's worth it for LA County to do a universal mask mandate when some of your previous like-minded counterparts think it's no longer necessary? Two, a crystal ball question. I think we all were hopeful that we were turning the corner, and there are trends in the Northeast suggesting that cases and hospitalizations are declining there. And in the Bay Area, it's a little bit weird. Cases are decreasing, but viral levels in wastewater are increasing. And so officials in the Bay Area are warning they haven't really turned the corner yet. Based off of this wastewater data, do you think are you hopeful that we're turning the corner, or is it too early to hazard a guess? And then finally on monkeypox, are the two suspected monkeypox cases in LA County related to each other? And are there any signs of community spread here? And are there any reports of any serious symptoms? CDC mentioned that some symptoms include people who have the sores that are so painful they need to get prescription painkillers to deal with the pain. Thank you.
Yeah. Yeah, thanks so much. Maybe I'll start with monkeypox. We do have 2 cases of monkeypox. One that's been confirmed by CDC, one we're waiting for that confirmation of positive orthopox test, likely to be confirmed any day. They're not related. Both of the patients are with symptoms, but home and in isolation as we continue to, both monitor and provide any support and, really make sure we're in touch with close contacts. That's the information we have to share on those 2 cases. They're obviously not related, so no, we don't have any EpiLink cases here in LA County at this time. In terms of the future of mask mandates, why are some counties saying something different? And again, I do understand how much confusion this creates with the public, and wish it was easier. I do want to note, LA County looks more like Alameda than it does like San Francisco County, and share, I think, a similar perspective on the ease of which we can go ahead and add in a very important and powerful safety measure with masking and the impact that can have, particularly on the disproportionate effects of high transmission in some communities when compared to others. So, and in particular, we continue to see higher rates of hospitalizations and higher rates of death among communities of color and among people who live in communities that have higher rates of poverty. So, at a point where CDC has said, you got so much transmission, it's really advisable that everyone is wearing a mask indoors, and you want to make sure we're doing everything we can to protect those most vulnerable. I think it makes a lot of sense for us to go ahead and align with that guidance. As I've noted all along, as frameworks have changed and we have the opportunity to watch what's going on, because I think you raised this really important question about so much uncertainty right now, particularly with the possibility that we could see some growth in BA.4 and BA.5, which in other parts of the world, South Africa, as a prime example, have really, both spread more quickly, but also caused more, our cause for more concern. So, again, we've got to get comfortable with the idea that when our numbers don't look great, it's really sensible to layer in some of the additional protections while we try to understand what might be going on with these emerging, sublineages of Omicron. So, yes, I think, there's an opportunity for us to need to go back to asking everyone to go ahead and put back on those masks as a required safety measure. We're not there, and as I alluded to earlier, I don't think we have to get there. I think there's still things we can do to avoid that. We obviously have different, sort of a different picture with our wastewater sampling than San Francisco right now. We're not seeing big increases at all in our concentrations. But I'm not sure that means we've turned the corner. And again, I want to note, one of the problems with turning the corner right now is the proliferation of new variants of concern. So, BA.2, then we have BA.2.12.1, definitely more infectious, capable of more spread, more easily spread. And then we have the possibility now of starting to see more BA.4 and BA.5. Will they sort of crowd out BA.2.12.1? We have no way of knowing, but we're going to be cautious. We're going to pay a lot of attention. We're definitely going to say it's too early to determine whether or not we've turned the corner. We don't see a lot of indications of turning the corner at the moment, but we'll continue to track all of our data, all of our early alert signals to help us better understand what's going on. We've seen a slight uptick again, small, but a slight increase in emergency department visits. So, again, that means that not only are people, getting infected, it's sort of potentially a higher rate, but some of those people are needing to go in to seek care. So again, we urge people, if you are testing positive, call your provider, call us, access that treatment opportunity if it's right for you, because it will help keep people out of the hospital. But most importantly, try to add in some protections so you don't inadvertently either get or spread COVID. So thanks for those questions. I think I got to both of them.
Dr. Freer, that concludes our question and answer period. Do you have any closing remarks?
No, just thanks a lot, everyone, for all you're doing to get good information out. And we'll talk to you next week.
Oh, my apologies. Thank you, everyone. For additional questions, please send them to our media inbox at media@ph.lacounty.gov. Thanks again for joining us, and if you stick around, we'll have Spanish remarks in just a minute. Hi, Jackie. Would you like to get started? Sure. All right, wonderful. Let me pull up your slides. Okay. Okay. Good afternoon, everyone. Thank you for joining us today for the Spanish portion of today's briefing. Today is June 9th, and we have Jackie presenting. Jackie, when you are ready.
Great, thank you. Buenas tardes y gracias por acompañarnos durante esta sesión informativa. Hoy comenzaremos con una actualización. Repasaremos las medidas actuales de nuestras señales de alerta temprana y discutiremos medidas de protección necesarias a medida que nos preparamos para el verano que tenemos por delante. First slide, please. La semana pasada vimos un aumento renovado en los casos informados después de una ligera disminución la semana pasada, un movimiento ascendente continuo en la positividad de la prueba y las hospitalizaciones, y un número estable de muertes informadas. Durante la semana pasada informamos muchos más casos en comparación con la semana pasada y hoy informamos 4,846 casos nuevos. Y como notamos la semana pasada, este número es una subestimación, ya que no incluye los resultados positivos de las pruebas de venta libre. El promedio de la cantidad de casos nuevos diarios informados la semana pasada, reflejando un aumento del 13% desde hace una semana y un aumento del 93% desde hace un mes. Nuestro promedio de 7 días de la tasa de casos diarios también aumentó y actualmente es de 48 casos por cada 100,000 residentes. Nuestra positividad de las pruebas aumentó a 4,7% y es casi el doble de la positividad de las pruebas de hace un mes. El aumento constante de las hospitalizaciones ha continuado y el promedio de 7 días de hospitalizaciones diarias llegó a 544 hoy. El promedio de las muertes se mantiene estable en alrededor de 7 muertes informadas por día. Cada muerte es una pérdida que se extiende a través de las familias y comunidades. Sabemos y entendemos que los afectados son cambiados para siempre por esta terrible pandemia. Next slide, please. Aquí vemos las líneas de tendencia más recientes para 3 indicadores claves. El promedio de 7 días de casos informados a diario, admisiones al hospital y muertes, que reflejan el aumento continuo en la transmisión. El promedio de 7 días de casos informados a diario, la línea verde, ahora ha vuelto a casi 4,900 después de una ligera disminución a principios de este mes. La disminución anterior probablemente estuvo relacionada con la reducción en las pruebas durante el feriado del Día de los Caídos, mientras que el aumento posterior puede estar relacionado con una mayor propagación asociado con los viajes y las reuniones durante el fin de semana largo del feriado. La tasa de admisiones hospitalarias ha seguido aumentando gradualmente. Nuestro promedio de 7 días de admisiones diarias al hospital, la línea anaranjada, ahora son 77, cual representa un aumento de más del 135% que las admisiones de hace solo un mes. El promedio de 7 días de la cantidad de muertes informadas, la línea azul, permanece estable en alrededor de 7 muertes por día. Next slide, please. Esta semana nos mantenemos en el nivel comunitario medio de los CDC. Esta semana nuestra tasa de casos es de 310 casos nuevos por cada 100,000 habitantes. Los 2 indicadores hospitalarios del nivel comunitario de los CDC aumentaron. El primer indicador hospitalario, la tasa de 7 días de nuevas admisiones por cada 100,000 residentes, aumentó a 6,4 admisiones nuevas por cada 100,000 residentes, que es casi el doble que hace solo un mes. El segundo indicador hospitalario, el promedio de 7 días de la proporción de camas hospitalarias que tienen personal y están ocupadas por pacientes con COVID, aumentó al 3,1%. Aunque estos indicadores hospitalarios aún se encuentran por debajo del umbral del nivel alto en el marco del nivel comunitario de los CDC, los aumentos continuos nos acercan al umbral de alto nivel de 10 nuevas admisiones por cada 100,000 personas. Next slide, please. Esta semana repetimos nuestro análisis sobre cuándo las admisiones hospitalarias podrían superar 10 admisiones nuevas por cada 100,000 por semana. Si continúan aumentando al mismo ritmo que se vio entre el 24 de mayo y el 6 de junio, las admisiones hospitalarias podrían alcanzar este nivel a principios de julio, un poco más tarde de lo que habíamos proyectado la semana pasada. Este cambio se debe a que la tasa de aumento en las admisiones hospitalarias se desaceleró ligeramente en las últimas 2 semanas. Como recordatorio, la proyección en este gráfico asume que mantenemos el mismo promedio del aumento en la tasa de admisiones hospitalarias que vimos durante el periodo reciente de las últimas 2 semanas. La tasa real de cambio en las admisiones hospitalarias podría ser muy diferente. Sin embargo, esta proyección nos ayuda a tener en cuenta que podríamos pasar de un nivel medio a un nivel alto en el marco del nivel comunitario de los CDC en un futuro cercano si continuamos viendo aumentos en las admisiones hospitalarias. Una estrategia importante para reducir las admisiones hospitalarias es reducir la transmisión comunitaria. Dado un retraso habitual en los aumentos de hospitalización, si reducimos la cantidad de casos nuevos en las próximas semanas, podríamos ver una disminución en las admisiones hospitalarias nuevas un par de semanas más tarde. Next slide, please. Esta semana, la mayoría de nuestros 8 indicadores de alerta temprana continúan siendo motivo de preocupación media o alta. La única señal de alerta temprana con un nivel de preocupación bajo es la cantidad de sistemas locales con un aumento del doble o mayor en la concentración de SARS-CoV-2 en las aguas residuales. Si bien la concentración de SARS-CoV-2 en las aguas residuales sigue siendo alta, no se informaron aumentos significativos en los niveles de concentración desde la semana pasada. Desafortunadamente, la cantidad de nuevos brotes en centros de enfermería especializada en los últimos 7 días vuelve a ser motivo de gran preocupación, con 40 nuevos brotes informados la semana pasada en las 341 instalaciones en el condado de Los Ángeles. Esto no incluye en Pasadena y en Long Beach. Y tanto la tasa de casos en las comunidades con ingresos más bajos como el porcentaje de muestras identificados como nuevas variantes continuaron indicando un nivel de alta preocupación. Daremos más detalles sobre muchas de estas señales de alerta temprana en los próximos gráficos. Next slide, please. Omicron continuó representando todos los casos positivos de muestras secuenciadas que fueron recolectadas durante la semana que finalizó el 21 de mayo. Casi el 98% de las muestras continúan siendo BA.2 y sus sublinajes. La proporción de la variante Omicron BA2 en sí misma, excluyendo sus sublinajes, aquí en azul claro, continúa representando aproximadamente la mitad de las muestras secuenciadas en el condado. El sublinaje Omicron BA.2.3 continúa disminuyendo, representando solo alrededor del 3% de las muestras en la semana más reciente. Será interesante ver si desaparece por completo. Por el contrario, el sublinaje BA.2.12.1, aquí en anaranjado, representó el 42% de las muestras positivas que fueron secuenciadas en la semana que terminó el 21 de mayo, un pequeño aumento con respecto a la semana anterior. A nivel nacional, los CDC predicen que BA.2.12.1 representará el 62% de las muestras recolectadas la semana que terminó el 4 de junio. Las partes rojas aquí en la sección de arriba de la barra indica el porcentaje de muestras que dieron positivo para las subvariantes BA.4 y BA.5. Como puede ver, siguen siendo raros aquí en el condado de Los Ángeles, pero cada semana se detectan algunos casos. Hasta la fecha hemos detectado un total de 49 muestras secuenciadas que dieron positivo para estas dos subvariantes, 27 de BA.4 y 22 de BA.5. El CDC estimó que estas dos variantes en combinación pueden haber aumentado de aproximadamente el 1% al 13% de las muestras recolectadas el mes pasado. Esto sugiere que pueden tener la capacidad de superar a otras variantes en circulación. También existe la preocupación de que pueden causar reinfecciones en personas que ya han sido infectadas por otras subvariantes de Omicron. Estas circunstancias que cambian rápidamente nos recuerdan de la importancia de usar medidas que protegen contra todas las variantes, incluido el uso de mascarillas, mover las actividades al aire libre, mejorar la ventilación en espacios interiores y realizar pruebas y quedarse en casa cuando se está enfermo. Continuamos siguiendo de cerca los aumentos en los sublinajes BA.2.12.1, BA.4 y BA.5 de Omicron y evaluando su impacto en nuestras tasas de casos, hospitalizaciones y muertes. Next slide, please. A lo largo de los casi 2 años y medio de esta pandemia, nos hemos mantenido profundamente preocupados por los efectos de este virus en las personas que viven en comunidades con menos recursos, quienes han sufrido tasas más altas por lo general de casos, hospitalizaciones y muertes. Esta es la razón por la cual uno de nuestros indicadores de alerta temprana es la tasa de casos de 7 días para las áreas de ingresos más bajos. La semana pasada, la tasa de casos de 7 días para las áreas de ingresos más bajos, la línea roja, es motivo de gran preocupación por segunda semana consecutiva, ya que se aumentó de 220 casos nuevos a 232 casos nuevos por cada 100,000 residentes la semana pasada. Hemos visto aumentos repentinos en el pasado que comienzan primero en áreas de altos ingresos antes de pasar a áreas de bajos ingresos con menos recursos, con el potencial de más exposiciones en los lugares de trabajo y en la comunidad. La tasa de casos de 7 días cayó drásticamente para todos los niveles de ingresos en nuestro condado alrededor del Día de los Caídos, probablemente debido a una disminución en las pruebas. Sin embargo, entre el 31 de mayo y el 6 de junio, la tasa de casos aumentó considerablemente, un 23% en las áreas de ingresos más bajos y solo un 10% en las áreas de ingresos más altos. Continuaremos vigilando esta tendencia de cerca y alinearemos los recursos con las acciones de mitigación apropiadas. Next slide, please. Desafortunadamente, la cantidad de brotes por semana en los centros de enfermería especializada, la línea morada, aumentó considerablemente la semana pasada a 40 brotes nuevos durante los 7 días que terminaron el 7 de junio, lo que volvió el nivel de preocupación a nivel alto. Este fuerte aumento refleja el aumento en la transmisión en la comunidad en general. Cuando recomendamos las precauciones contra el COVID, una de las razones es porque todos tenemos una oportunidad colectiva de proteger a los más vulnerables de nuestra comunidad, incluidos los adultos mayores en hogares de personas mayores. Aunque el personal puede y toma muchas medidas adicionales para prevenir la transmisión en estas instalaciones, si las tasas de transmisión son altas en la comunidad que está alrededor de la instalación, aumenta la probabilidad de que los residentes y el personal estén expuestos a personas infectadas. Cuando usamos mascarillas y tomamos otras medidas de protección en tiempos de aumento de casos de COVID, estamos tomando medidas para proteger a todos nuestros residentes, incluidos los más vulnerables en nuestros hogares de personas mayores. Estamos trabajando en estrecha colaboración con los centros de enfermería especializada para investigar y detener los brotes. Los trabajadores y residentes en estas instalaciones continúan manteniendo medidas de protección mejoradas, incluidos los requisitos de prueba y mascarillas en interiores para residentes, personal y visitantes, aislar y poner en cuarentena apropiadamente a los residentes y limitar las comidas comunitarias y las actividades en grupo. Durante el mismo periodo de tiempo, los nuevos brotes de personas sin hogar, la línea verde, disminuyeron ligeramente, manteniendo el nivel de preocupación en el nivel medio. Nuestros equipos continúan facilitando las pruebas y refiriendo a sitios de cuarentena y aislamiento y brindan fácil acceso a mascarillas, vacunas y dosis de refuerzo para personas sin hogar. Se requiere el uso de mascarillas en interiores en todos los albergues y sitios de alojamiento provisional. Next slide, please. Los indicadores de alerta temprana también indican un aumento continuo en la transmisión de COVID-19 informada en los sitios de trabajo, con 259 informes de grupos de casos en sitios de trabajo recibidos para el periodo de 7 días que terminó el 7 de junio. Un aumento de 186 informes de grupos de casos en sitios de trabajo recibidos para el periodo que terminó el 31 de mayo, y el doble de grupos de casos de los que informamos durante un periodo de 7 días hace aproximadamente un mes. De estos grupos de casos, la mayoría eran entre 3 sectores, con un 23% solo en el sector de comercio minorista, particularmente en tiendas de alimentos y bebidas y distribuidores de material de construcción y equipos y suministros de jardinería. Otras empresas frecuentemente representadas fueron en los sectores de manufactura y servicios personales, científicos y técnicos. Hay una excelente orientación y rótulos de seguridad contra el COVID que todas las empresas pueden usar y está disponible en nuestro sitio web. También contamos con un equipo listo para ayudar a responder a las preguntas de las empresas. Mantener a los trabajadores y los lugares de trabajo a salvo de la propagación del COVID no es fácil y requiere múltiples medidas, así como la capacidad de cultivar una cultura de seguridad. Hay muchas empresas en todo el condado que están haciendo exactamente eso. Lo reconocemos y les agradecemos. Next slide, please. Los brotes en las aulas escolares siguen siendo de preocupación media, como lo han hecho durante más de un mes. Para la semana que terminó el 7 de junio, se abrieron 11 nuevos brotes en las aulas. 8 fueron en escuelas primarias, 1 en una escuela intermedia y 2 en escuelas secundarias. A lo largo del mes pasado, han habido 15 brotes grandes asociados con excursiones del fin de año, presentaciones escolares y eventos como bailes de graduación, con más de 750 casos entre estudiantes y personal. Next slide, please. Como se espera durante un periodo de alta transmisión comunitaria, el número de casos entre estudiantes y personal aumentó casi un 75% durante el último mes. Durante la semana que terminó el 29 de mayo, hubo 7,854 casos en escuelas a través del condado, de las cuales 6,362 fueron entre estudiantes y 1,492 entre el personal. Hace un mes, para la semana que terminó el 1 de mayo, hubo 4,479 casos, de los cuales 3,647 fueron entre estudiantes y 832 entre el personal. La positividad de las pruebas se duplicó el mes pasado en las escuelas. Para la semana que terminó el 3 de junio, la positividad de la prueba fue del 1,16% en comparación con el 0,5% la semana que terminó el 6 de mayo. La tasa de casos más alta en el condado se encuentra entre los adolescentes de 12 a 17 años, con 762 casos nuevos de COVID por cada 100,000 adolescentes. Esta tasa es más del doble de la tasa de hace solo un mes, cuando había 363 casos por cada 100,000 adolescentes. Al 4 de junio, la tasa de casos para niños de 5 a 11 años era de 588 por cada 100,000 niños, un aumento del 96% con respecto a hace un mes, cuando la tasa de casos era de 300 por cada 100,000 niños el 4 de mayo. Las altas tasas de casos reflejan una transmisión elevada de las variantes de Omicron entre los niños. Y aunque la mayoría de los niños sufren una enfermedad leve, los niños no vacunados corren un mayor riesgo de sufrir una enfermedad grave y el síndrome inflamatorio multisistémico infantil. Durante los últimos 3 meses, los niños no vacunados de 12 a 17 años tenían casi 4 veces más probabilidades de ser hospitalizados que los niños vacunados del mismo grupo de edad. Además, el 65% de los niños elegibles para la vacuna con casos confirmados de este síndrome no estaban vacunados. Después de ver nuestros datos sobre casos y hospitalizaciones entre niños en edad escolar, queremos tomar un momento para abordar la percepción errónea, pero común, de que el COVID solo causa una enfermedad leve en los niños. No se equivoque, COVID es una enfermedad infantil preocupante. En todo el país, más de 1,500 niños han muerto a causa de COVID desde el comienzo de la pandemia y aproximadamente 1 de cada 3 niños hospitalizados con COVID terminaron en unidades de cuidados intensivos. En el condado de Los Ángeles ha habido 11 muertes por COVID entre niños desde marzo del 2020, pero solo una muerte por gripe entre niños durante el mismo periodo de tiempo. Se acaba de publicar un nuevo estudio que aún está en preimpresión, que examina las causas principales de muerte entre los niños en los Estados Unidos entre marzo del 2020 y abril del 2022. Descubrieron que COVID ocupó el puesto número 9 entre todas las causas de muerte de niños entre las edades de 1 año a 19 años. COVID ocupó el puesto número 5 en las causas de muerte relacionadas con enfermedades y el puesto número 1 en muertes causadas por enfermedades respiratorias infecciosas. Next slide, please. A partir de la próxima semana, muchos niños comenzarán programas recreativos que incluyen campamentos, ofreciéndoles la oportunidad de explorar nuestro hermoso condado. Queremos animar a todos los padres a pasar un tiempo revisando los protocolos de seguridad de COVID, de los programas y campamentos recreativos a los que puede asistir su hijo y también a preparar a su hijo para estar lo más seguro posible contra el COVID. Los requisitos y recomendaciones de seguridad contra el COVID son muy similares para escuelas y campamentos. Al igual que en las escuelas, existe el riesgo de brotes, especialmente en los campamentos que tienen mucha actividad en espacios interiores. Uno de los pasos esenciales que puede tomar un campamento es tener protocolos contra el COVID que sean muy claros y que se compartan con anticipación con los padres y los niños que asisten a estos campamentos. Incluido en estos protocolos debe haber un proceso bien definido para asegurar que todos estén saludables todos los días. Recomendamos que los campamentos y los programas recreativos requieran el uso de mascarillas en interiores y en vehículos. Este es uno de los pasos más simples y efectivos para reducir el riesgo. Como hemos visto en las escuelas, las pruebas de rutina aumentan la seguridad al identificar a las personas infectadas que no tienen síntomas para luego ser excluidas. Los campamentos durante la noche deben considerar solicitar una prueba negativa antes de la llegada. Los campamentos diurnos y los programas recreativos deben considerar exigir pruebas semanales, especialmente si sus actividades incluyen actividades de mayor riesgo, como los deportes en espacios interiores. Los directores de campamento pueden obtener ayuda para acceder a pruebas gratuitas, comunicándose con nosotros por correo electrónico al acdc-education ph.lacounty.gov. Reducir la mezcla de personas puede ayudar a prevenir grandes brotes. Mantener a los niños en grupos designados, cohort se le dice en inglés, es el proceso de hacer que los campistas permanezcan dentro de su propio grupo mientras están en el campamento, especialmente en espacios interiores. Y es una estrategia que se puede usar para limitar el potencial de propagar el virus entre un gran número de personas. Dado los horarios ocupados en muchos programas, para la mayoría de los campistas se recomienda, como parte de los protocolos de control de infecciones, que el lavado de manos en grupo se programe varias veces durante el día, especialmente antes de las comidas o meriendas. Los buenos estándares de control de infecciones también deben incluir desinfección diaria de superficies que se tocan con frecuencia, incluyendo manijas de las puertas, baños y equipo deportivo que sea utilizado por muchos niños. Los campamentos que aprovechan al máximo el aire libre son más seguros que los campamentos bajo techo. Incluso si la programación central no se basa en la recreación al aire libre, realizar reuniones en grupo al aire libre, siempre que sea posible, reduce el riesgo y permite a los campistas quitarse las mascarillas de manera segura. Los campamentos pueden preparar sus espacios al aire libre ahora para agregar sombra y asientos para facilitar este tipo de reuniones al aire libre. Para actividades que no se pueden mover al aire libre o para acampar durante un clima variable, se debe optimizar la ventilación. Si es seguro hacerlo, abra puertas y ventanas. Colocar un ventilador en una ventana que sopla hacia afuera ayuda a sacar cualquier partícula de virus en el aire fuera de la habitación. Los sistemas de aire acondicionado deben proporcionar entre 2.5 y 6 cambios de aire por hora. Se necesita más si hay mucha gente. Y tener un filtro MERV de 13 niveles en el sistema, si el sistema puede manejarlo. Las áreas interiores que no están ventiladas se pueden hacer más seguras mediante el uso de purificadores de aire portátiles con filtros HEPA. Si bien las acciones que mencionamos anteriormente son fundamentales para evitar la propagación de COVID en campamentos y programas recreativos, instamos a los padres a asegurarse de que todas las actividades organizadas para niños cuentan con el personal adecuado de consejeros capacitados que pueden garantizar seguridad óptima, especialmente para actividades cerca de o en el agua. Como recordatorio, se requiere que los campamentos y los programas recreativos informen todas y cada uno de los casos de COVID en un campista, personal, miembro o voluntario a salud pública. Esto permite una implementación rápida, según lo determine salud pública, de estrategias para detener o controlar los brotes. Next slide, please. Los padres y cuidadores pueden hacer mucho para preparar a los niños para una experiencia de campamento segura y divertida. Es importante asegurarse de que sus hijos estén al día con todas las vacunas infantiles recomendadas, incluso contra el COVID. Puede consultar a su pediatra o nuestro sitio web vacunatelosangeles.com para obtener más información. Tome un momento cada mañana antes del campamento para preguntarle a su hijo cómo se siente. Si no sienten síntomas, si no se sienten bien, que tienen síntomas similares a los de COVID, considere hacerles una prueba de COVID en casa o consulte a su pediatra. No los envíe al campamento ese día si no se sienten bien, especialmente si dan positivo. Si se sienten bien y están listos para ir al campamento, envíelos con protector solar, desinfectante para manos, mascarillas bien ajustadas y mucha agua. Next slide, please. Para terminar, queremos proveer un par de actualizaciones rápidas sobre las vacunas. Esta semana, el Comité Asesor de la FDA votó para recomendar la vacuna de COVID llamada de Novavax para su uso en los Estados Unidos. Como resultado, la FDA puede decidir permitir el uso de Novavax aquí al otorgarle una autorización de uso de emergencia. Novavax es una vacuna de 2 dosis y está diseñada para usarse en personas mayores de 18 años. Se fabrica con base en una tecnología de la vacuna recombinante, el mismo tipo que se usa en algunas vacunas que no son contra el COVID, como las que se usan comúnmente para proteger contra la hepatitis B. Esta vacuna se puede almacenar a temperaturas de refrigeración, por lo que es más fácil de almacenar que el congelador más frío que es necesario para las vacunas contra el COVID de Pfizer y Moderna. Se encontró que la vacuna era 90% efectiva para prevenir infecciones y 100% efectiva para prevenir enfermedades graves, pero estos datos se basaron en estudios realizados entre diciembre del 2020 y septiembre del 2021, lo que significa que la mayor parte del estudio se realizó antes del predominio de Delta y todo el estudio se llevó a cabo antes de la aparición de Omicron. Se está evaluando la efectividad de Novavax contra Omicron. Actualmente no hay suministro de Novavax en los Estados Unidos y aún no se han asignado fondos federales para comprar la vacuna. Sin embargo, el gobierno federal ha indicado que puede estar disponible en algún momento a fines del verano. Y la segunda actualización es sobre vacunas para niños pequeños. El Comité Asesor de la FDA que revisa las vacunas está programado para revisar las solicitudes de autorización de uso de emergencia para el régimen de vacunas de 3 dosis de Pfizer para niños entre 6 meses y menores de 6 años el 15 de junio. El 14 de junio, el mismo comité asesor de la FDA también revisará la solicitud de Moderna para su vacuna de 2 dosis para niños entre 6 a 17 años. El comité de los CDC que revisa el uso de vacunas está programado para reunirse para revisar las vacunas y cualquier autorización de la FDA el 17 y el 18 de junio y emitir recomendaciones finales. Esto probablemente significa que si se aprueba la vacuna para nuestros residentes más pequeños, niños menores de 5 años, podría estar disponible a partir del 21 de junio. Muchos proveedores locales ya han realizado pedidos a través de salud pública para prepararse para administrar vacunas a niños pequeños empezando el 21 de junio si se aprueban. Continuaremos brindando actualizaciones sobre los detalles del lanzamiento de vacunas para niños pequeños a medida que haya más información disponible. Visiten nuestra página web vacunatelosangeles.com para obtener la información más reciente. Y para terminar, a medida que comenzamos nuestro verano con mucha incertidumbre con respecto a la trayectoria de la pandemia, dada la circulación de enfermedades altamente infecciosas. Estamos comenzando la temporada con una nueva ola en la pandemia y tenemos nuevas subvariantes de Omicron. Mantenemos la esperanza porque tenemos más conocimiento, experiencia y herramientas que nunca antes que podemos usar para protegernos a nosotros mismos y a los más vulnerables. Al agregar más capas de medidas de seguridad de sentido común que abordan los riesgos muy reales durante los momentos de alta transmisión, podemos sentirnos cómodos realizando muchas de nuestras actividades habituales del verano. Okay, thank you so much.
Thank you so much, Jackie, and thank you to everyone who joined us today. As a reminder, additional media questions can be sent to our media inbox at media@ph.lacounty.gov. Once again, thank you, and we'll see you next week.